if you're working in the hand therapy world and you get confused about when is it safe to do active range of motion versus passive range of motion based on the injury that you're receiving, well, my name is Huang. I'm an occupational therapist and certified hand therapist, and I help other therapists develop their clinical skills in the area of hand therapy. Now, I had a student of mine inside the mentorship program ask me this very question, and it's very common. Like it's easy to get confused. When is it safe to do active, passive, and what the hell is active assisted range of motion anyway? So I go into this detailed explanation based on the nature of the injury. Take a listen to this video. Hey Liz, thanks for the question. I think it's a great question. All right, so let's talk about the different passive range of motion versus active range of motion, and not always sure when to initiate passive range of motion, which is correct because you're not always initiating passive range of motion first. Sometimes it's active first and then passive. Sometimes it's passive and then active, right? So passive range of motion just means the patient's not doing it. You are manually moving it by yourself. And of course, passive range of motion is based also on degrees, right? So if someone's joint is really loose, when you do passive range of motion, it's not very aggressive because it's by its nature, they're loose already. When it is more stiff and rigid, then you might be doing more critical aggressive range of motion. So specifically, you have a patient 4 weeks post-surgical middle finger distal phalanx dislocation and fracture. We're talking about middle finger distal phalanx, no weight bearing. I love it when they're like no weight bearing. Who the hell's weight bearing on their finger? Anyway, weight bearing as tolerated. And to start active and passive range of motion. In your head, I'm associating passive range of motion with stretch, which I know is not the case, but do you have a way to break down the different range of motion and when it's appropriate based on healing times? Absolutely. So range of motion is based on how do you call it? The frameworks, right? So let's say I have a bone issue, a muscle tendon issue, and a ligament issue, right? So in the terms of a bone issue, if you have a fracture, right? If you have a fracture, once that fracture is stable, unstable, right? So most of the time, a fracture, if it's unstable, is going to be immobilized, isn't it? Once it's immobilized and it becomes more stable, then you can move it. Then it becomes stable. So if you have a fracture and it's stable, AKA it could be a surgery or something like that, or just by the nature of the fracture wasn't that bad, it's stable, you are allowed to move it. So then it becomes, well, how can you move it, right? How can you move it? So here, when it's stable, you would essentially start with an active range of motion. And then as it becomes more stable, you can do passive range of motion, right? So the key timeline when it comes to fractures is bone healing. So the nature of the injury, the nature of the tissue, right? Going back to that fast track framework, the nature of the tissue is bones heal within 4 weeks. There's a certain amount of clinical healing around 4 weeks, 4 to 6 weeks. And so by 4 weeks, if they're more stable, you might be able to start gentle passive range of motion, right? And by 6 weeks, you can do more aggressive passive range of motion. And all the whole time, you can do active, right? So if you start doing active and they get better and better, then you want to get more range of motion. So then you're going to go passive range of motion so that you're moving and stretching all the tissues. You're stretching and the tendons and the muscles, you're stretching the ligaments, you're moving the skin and fascia. And so then you get more passive range of motion. So when you get more passive range of motion, then you're able to do actually more active range of motion, can't you? Right? So in your case, this is a fracture plus ligament dislocation. So you have two problems, right? So now we have to take into account, let's go into ligaments, right? So ligaments hold bone and bone together. So if the ligaments hold bone and bone together and something happened to it, it's torn, it's sprained, it's strained, do you want to passively move it? Probably not. You have to let it stiffen, let it harden, and then you start to do active range of motion, and then you can move into passive range of motion as you have more stability, right? So if you always go back to the nature of the tissue, ligaments hold bone and bone together and provide stability. So if it's unstable, do you want to push on it some more and make it more unstable? No, you actually want to let it stiffen up, right? And then let it get more stable, and then you can start to move it. So the safe way to move it's active range of motion, and then as it becomes more stable, then you can do more passive range of motion, right? So if you have a two-part problem, right? You have a two-part problem. You have bone and ligament. Now you have to determine, is the bone stable enough for me to move it? Now, if we have to stabilize it for the bone, then by default, the ligaments have to be stabilized as well, right? So if you're 4 weeks out, right, 4 to 6 weeks, if you're like ligaments sometimes need more time, right? But that is dependent on location. In the fingers, they usually tend to be more stable because the ligaments are just tight all the way around. So usually around 4 weeks, you can start to do active range of motion. And then if they're able to tolerate, you can start to do passive range of motion as well, right? So the doctor is saying you can start both. But what do you feel like you're able to start with? Well, if I don't know this person, I'm going to start with some active range of motion because I want to see how they move and how they respond. Once I see, hey, they're moving okay, they're responding okay, I'm going to start to add more passive range of motion into it so that they can get more active. And then when they get more active, then I can get more passive. So it's it's this round robin thing, right? Now, I also have to always take into account tendon issues, right? So let's say, for example, I only have a tendon problem. Which one is it? Is it a flexor problem or an extensor problem, right? Herein lies the difference because the tendons, due to its location, plays a role in whether you can do passive or active first, right? So in the flexor tendons, they're over here. They're big and they're long. And when we're able to put them into a safe position so it's not so tight, and once it's healed, we're allowed to, once they suture it together, we're allowed to do passive range of motion because we need the glide. So in the flexor tendon issue, we do number 1, passive range of motion first, and then 2, active as it heals. As the sutures heal, as they're scarring, we're able to do more active. And the reason why is because when you do more passive, it loosens up the joint. So there's less drag and stress on the repaired tendon, right? So if you think about it, this is the one structure, the flexor, this is the one structure that you do passive and then active, right? Now, if you look at extensor tendon, also based on its location, right? Based on its location, I was just talking about extensor tendons to someone, right? The only way to make it slack is to be in extension, so it's on slack, right? And because of the direction of pull, when you go into a fist, it's going to stretch it. So if the tendon, the nature of the tendon needs to be repaired, right, sutured together, because there's no blood supply, all right, no blood supply, it relies on the sutures, it relies on the scarring, right? So if I go and I suture it and I stretch it out too far, too fast, I can have issues, right? So with an extensor tendon, you have to, at the very beginning, either have no motion, depending on where it is. Then you can start once you hit a time period. That's why you have to now know some of the details of timeline. Then you can start into active range of motion, and then as it heals and it gets stronger, then you can move into passive range of motion. All right. So you have to essentially know the structures, right? You have to know the structures. So it goes down to knowing your anatomy, right? Doesn't it go down to knowing your anatomy, right? Fast track framework. Is it a bone issue? Is it a ligament issue? Muscle, tendon? Is it a nerve? Is it skin and fascia? After you know that, you have to know the nature of the injury, and potentially surgery, right? You have to know the nature of the injury and nature of the surgery. From that, you really need to know the date of the injury or the date of the surgery so that you can work into protocols. So you can work into timelines. Say, based on X, Y, and Z, I'm allowed to move here, here, and here, right? So for the most part, can we clump most of it up? Sure. But you can have a broad overall picture and then dial into the details based on your injury and based on location. Because yes, we can talk about extensor tendons a certain way, but they're different at different parts of the fingers, right? If you're talking about a terminal tendon, dude, terminal tendons, what do you understand about the nature of that structure? Well, it's very thin, very small, very weak, right? So if you start stretching the hell out of it and it's not really, if it was disrupted somehow, you might discover that you're going to get a lag, right? So you got to watch out for that just in case, right? The dislocation just means like it's going to be really stiff. So you're going to have a joint issue and you're going to have to do passive range of motion, do some joint distraction, right? Do some passive, I like to do passive rotations to loosen up the ligaments or whatever. And then you can also do passive, but when you do passive, you have to also make sure active that it goes up, right? And it goes down. And then active assisted is really like, passive is completely, you do it by yourself, right? Active is they do it by themselves. Active assisted is, okay, I'm gonna, you're gonna bend down and I'm going to help you. So go into block that finger, bend that little knuckle. They're going to bend, and then you're going to go and you're going to stretch it further. Bend it. You're going to go and stretch it further. That's a little bit more active assisted range of motion because they do some work, you do some work. All right. And that's essentially how I tell my patients, literally the same way. So I hope this video helps to guide your thinking and breaks down passive, active, and active assisted for you. Hey, listen, I hope you enjoyed that video. If you have any follow-up questions, leave me a comment below. And if you're interested in any of the programs I have, the links are below as well.